Good afternoon to anyone present here. I'm Dr. Lahari and I'm going to be presenting a case report on drug-induced acute angle closure glaucoma. So coming to the introduction, several systemic and topical medications may induce acute angle closure glaucoma, which is an ophthalmic emergency, and it acts via two mechanisms. One is the pupillary block mechanism and the other is the non-pupillary block mechanism. Medications implicated can be topical cholinergic drugs, sulfa drugs, and antipsychotic drugs, amongst many others. Coming to the case report, a 43-year-old female patient came to the emergency room with chief complaint of headache, which was holocranial, severe, and associated with nausea and one episode of projectile vomiting without neck stiffness or fever. Patient was admitted under neurology for headache and was diagnosed as migraine, and she was started on tablet pregabalin 75 mg plus nortriptyline 10 mg once daily at night, tablet thiacolchicide 8 mg and aceclofenac and paracetamol combination twice daily, and capsule duloxetine 20 mg once daily, along with an IM injection diclofenac stat. She developed blurring of vision both eyes the next day after using one course of prescribed medication, which was sudden in onset, bilateral, painful, with redness of eyes and associated photophobia. She was a known hyperopic and a known case of migraine since 5 years and was started on tablet naproxen sodium 500 mg SOS, tablet gabapentin 75 mg and duloxetine 20 mg once daily, which she has been using on and off. On our ocular examination, best corrected visual acuity in the right eye was 6/24 and 6/18 in the left eye. Conjunctiva showed circumcorneal congestion in both the eyes. Cornea showed diffuse epithelial edema and corneal sensations were present. Anterior chamber was shallow with von Herix grade 1. Her pupil was 3 mm in size and sluggishly reacting to light in the right eye while it was briskly reacting in the left eye. Fundus media were hazy and 0.4 cup disc ratio was noted. On applanation tonometry, 56 mm of mercury pressure was noted in both the eyes. Gonioscopy, we could not visualize the angles due to corneal edema. Beside are the pre-op pictures showing a shallow anterior chamber. As part of our management, the patient was asked to stop medications for migraine immediately, namely gabapentin, nortriptyline, and duloxetine. Treatment given was tablet acetazolamide 500 mg stat, and an IV mannitol infusion of 1 gram per kg was given over 20 minutes with vital monitoring. However, her post-infusion IOP measure was only 42 mm of mercury in both the eyes, even 1 hour after infusion. She was immediately started on anti-glaucoma medication, and IOP after 1 day of treatment was 18 mm of mercury. However, gonioscopy at that point also showed closed angles in both the eyes. She was then planned for a laser peripheral iridotomy under 2% pilocarpine. Beside are the pictures showing the transition from a pre-op state to a post-LPI state. After LPI, she had 18 mm of mercury of intraocular pressure and partially open angles. Over here, we can see on the follow-up day, which is 3rd day after LPI, her intraocular pressure was once again noted to be 10 mm of mercury, and angle was anterior chamber depth was normal in this state, and gonio also showed partially open angles. Conclusion: this is a case of primary angle closure with occludable angles, which developed acute angle closure glaucoma due to migraine medication, namely tablet duloxetine, pregabalin, and amitriptyline. Preventing such attacks is important, and screening should be advised while prescribing implicated medication.